Okay, so now we're going to go ahead. We're going to have one case and then two didactic lectures, and then we're going to have an interactive panel discussion. Then we'll go to our second case, followed by two lectures and then an interactive panel discussion. Okay, so we are going to start off with our esteemed presenter, Tony Mint, to talk about a case of abdominal pain and diarrhea.
Thank you, Dr. Chang. It's very nice of you. My name's Tony. I'm one of the third-year GI fellows here. It's a tremendous honor to be part of the Mellinkoff Symposium. So the case I'm going to be talking about today is a patient that Dr. Chang and I saw in clinic a couple months ago. So this is a 31-year-old female with a history of recurrent childhood UTI who presented to us with a primary complaint of chronic diarrhea and abdominal pain. In talking to her a little bit more about her symptoms, it turns out that she's actually had a history of chronic childhood and adolescent constipation that responded very well to a course of osmotic laxative, as well as a course of anorectal biofeedback, both of which were done by an outside provider, presumably for dysenergic defecation. She did very well from a GI symptom standpoint for many years, up until about her mid-20s, when she was then enlisted in the military and subsequently enrolled in college. And in that context, she then developed her current symptom pattern of rectal urgency, diarrhea, and chronic abdominal pain. So when you ask her a little bit about her bowel habits, it turns out that she's having these episodic diarrheal episodes characterized by increased frequency and loose form. These episodes are usually preceded by rectal urgency, which at some points can be quite severe to the point of incontinence, and oftentimes preceded by crampy, nonspecific abdominal pain that remits after passage of a stool. Her episodes can also be provoked by both food and stress, although she has difficulty pinpointing exactly what food triggers consistently will cause her symptoms. These episodes, on average, will occur and occupy about 3 days of the week, with the remainder of the days of the week essentially being free of these episodes, with milder versions of the symptoms. She stopped her Miralax, or polyethylene glycol, a few months ago without improvement in her symptoms. Her abdominal pain is similarly episodic, usually associated with these diarrheal episodes and improved after defecation. Interestingly, these pain episodes were also associated with both food and stress, and they occur on average about 1 to 2 days a week. So because she mentioned a lot about food and stress as potential triggers for her symptoms, we decided to explore that relationship a little bit more detail. So in terms of food, it seems that most meals actually provoke her symptoms. In fact, particularly her rectal urgency is very severe after most meals, usually about 20 to 30 minutes after. Again, she has difficulty pinpointing which food triggers cause this, but she thinks maybe fatty foods, spicy foods, and dairy might be triggers. She did read online about a FODMAP diet and tried it on her own without much success. She does note quite a bit of stress in her life, both external and internal, and particularly she has a lot of anticipatory anxiety about going out in public because she's always worried about her symptoms coming on in a public area where she doesn't have access to a toilet and potentially having an embarrassing accident. And for this reason, she's actually avoided going out entirely or avoiding prolonged travel for fear of these symptoms happening. And this has impacted her quality of life. Notably, she's had no relation of her symptoms with menstruation and no relation with sleep deprivation. And she's not having any nocturnal symptoms either. The review of systems, for the most part, is unrevealing. So for the sake of time, I'll just summarize here. There's a little bit of fatigue, a little bit of nausea, but importantly, there's no red flag symptoms to suggest an organic GI process, no rectal bleeding, no unintentional weight loss. The ancillary history is similarly unrevealing. We did touch upon a little bit of her childhood urinary tract infection history, but that is no longer an issue for her in adulthood. She has no surgeries. She only takes supplements over the counter sporadically, which haven't had any improvement in her symptoms. She works in consulting, which she also finds stressful. And her family history is unremarkable for any organic GI disorders. And lastly, her physical exam is largely unrevealing. So at this point, I think many of us in the audience probably have a pretty good sense about what's going on with this patient. But for me personally, one thing that I often find is very challenging is how to make a positive diagnosis for a disorder of brain-gut interaction and how to do it in a cost-effective way. So as it turns out, conveniently, the Rome Foundation has actually put forward a number of diagnostic algorithms. This is the one for recurrent abdominal pain and altered bowel habits. So let's say, for example, you have a patient coming in for chronic recurrent abdominal pain and altered bowel habits. Obviously, the first thing you'd want to do is to get a better sense of what their symptoms are like. But you also want to understand the context within which their symptoms are arising. This includes a very detailed medical, surgical, biopsychosocial, medication, dietary history, as well as a physical exam. And then based on the aggregate of the data you've collected from your history and physical, if there are any alarm features that are concerning for an organic process, then it's totally reasonable to pursue a more thorough objective workup, including consideration for an endoscopy. And based on your findings, if there's any abnormality, then obviously you would tailor your management and workup based on that. But even in the absence of alarm features, the Rome Foundation and many of the major GI societies still recommend at least a limited objective workup because there are still organic processes that could masquerade as a disorder of brain-gut interaction. So these include things like a CBC, a CMP, a fecal calprotectin to look for nascent IBD, celiac serologies to look for potential celiac disease. So assuming that you have no alarm features and you have essentially a normal limited screening exam, then you are likely in the realm of a disorder of brain-gut interaction. And if abdominal pain is the predominant feature of your presentation, and your altered bowel habits meet the criteria for IBS, then it's very reasonable to make a provisional diagnosis of IBS at this point without any further workup. And then based on the predominant pattern of their abnormal bowel habit, you can then subtype them as one of 4 potential IBS subclasses, which for the sake of time I won't go into, but we'll likely touch on later on today. If abdominal pain is not the predominant feature, but rather the altered bowel habit is, then it's reasonable to make a provisional diagnosis of either functional diarrhea or functional constipation, again, based on the predominant bowel feature, or bowel habit, I should say. And I did want to point out here that even though we think of functional diarrhea and functional constipation as being pain-free syndromes, they actually exist on a spectrum with IBS, and that you can still have very mild degrees of pain or discomfort, but reasonably make a diagnosis of either of these disorders. I also wanted to note that certain patients may be diagnosed with one thing, but over time may switch between these different disorders. So again, kind of highlighting the importance of this being a spectrum. So this again is the Rome 4 diagnostic criteria, which we've all seen before. And just going back to our case, recall that our patient had recurrent abdominal pain, on average about 1 to 2 days per week, had been ongoing for a while. It was related to defecation in the sense that it improved after passage of a stool, and it was associated with the onset of both loose stools and an increase in frequency. So she met the criteria for IBS. And then based on her predominant stool pattern, which is predominantly diarrheal, she meets the criteria for IBS-D. So these are the studies that we ordered, and some of which had been done by the referring gastroenterologist, and for the most part, these were unrevealing. So just highlighting that we did pursue some limited objective testing. So ultimately, we made a diagnosis of IBS-D for this patient. So with that, I will pass off the microphone to our amazing division dietitian, Kate Evans.
Hi, thank you all so much. I'm Kate Evans. I'm one of the registered dietitians with the UCLA GI Nutrition Program, and today I'll be presenting on management of food sensitivities and intolerances. So I'll start by comparing 3 food-related reactions: food allergies, food intolerances, and food sensitivities. A food allergy is an immune-related response to food that causes production of IgE antibodies and can result in both GI and extraintestinal symptoms, with the key differentiating factor being the extraintestinal symptoms, including things like itchy mouth, hives, and breathing difficulties. The 9 most common food allergens are milk, eggs, fish, shellfish, peanuts, tree nuts, wheat, soy, and sesame. If a patient doesn't have a history with allergic reactions, but they are reporting symptoms with intake of certain foods, then this could be either a food intolerance or a food sensitivity. A food intolerance is an undesirable reaction to food that results in GI symptoms only, whereas a food sensitivity is an allergy-like response to food that can result in both GI symptoms and extraintestinal symptoms. And some examples of food intolerances include lactose intolerance, intolerance to different types of high FODMAP carbohydrates, and sucrose or starch intolerance, also known as sucrase isomaltase deficiency. An example of a food sensitivity is non-celiac wheat sensitivity. And I'll talk about each of these in more detail throughout the presentation. So food intolerances impact about 20% of the population, and they're particularly common in IBS patients, with 84% of patients reporting symptoms with intake of certain foods. What research has shown is there is an association between a larger number of reported food triggers and reduced quality of life in IBS, which highlights the importance of helping patients find the most liberalized diet possible to support their symptom management and quality of life. To diagnose most food sensitivities and intolerances, elimination and reintroduction protocols are the current gold standard. Food sensitivity testing is also becoming increasingly common, but also, as you'll see on the next slide, there's inadequate evidence for their use in clinical practice currently, although there is some evolving evidence for a specific type of IgG testing. You'll see on this slide a snippet of a food sensitivity test report, and this includes just a portion of the vegetables that were tested on this report. This panel included 190 foods in total, which, as you can imagine, often results in a very long list of foods flagged and a lot of confusion and restriction for the patient. So this slide contains some more details about 3 of the common types of food sensitivity testing. All 3 of these tests utilize blood samples to measure the response to food, but for all 3, there's pretty limited evidence that the responses measured are actually indicative of a food sensitivity. There has been shown to be poor reproducibility for the ALCAT test, and for IgG testing, we do expect to see an IgG response to food, even in healthy individuals, which can make it difficult to draw a clinically meaningful conclusion from these panels, especially when they're testing very large numbers of food, upwards of 200 foods commonly included on these panels. In terms of the evidence in disorders of gut-brain interaction, it's very limited for all 3. There is some evolving evidence for a specific type of IgG testing, and based on a 2022 DDW poster presentation and abstract, there was found to be an association between 18 specific foods and elevated IgG responses in IBS patients. When a panel of those specific 18 foods was used to guide diet changes, when the panel was used to guide the diet changes specifically with those 18 foods, there was found to be an improvement in abdominal pain and bloating in the IBS-C plus M group, but there were not statistically significant effects observed across the broader sample of IBS patients. So there is some promising research here that is still evolving and may potentially support the future use of a very narrowed down version of an IgG panel in IBS patients, but more research is still needed. And so given the limited evidence for food sensitivity testing, the best tool we have for diagnosing most food sensitivities and intolerance would be an elimination diet protocol. And these occur in 3 key phases. First, an elimination phase, which typically lasts about 2 to 8 weeks. Then, if the patient's symptoms improve with elimination, they would then move on to the reintroduction and maintenance phases, with the goal of determining their individual threshold for tolerance to each of the foods that they've eliminated and finding the least restrictive diet pattern for long-term symptom management. If the patient does not experience symptom improvement with elimination, they would instead return to their regular diet, or they might trial a different nutrition intervention. The number one issue I see with elimination diet protocols in practice is patients treating them as a one-phase elimination. So they eliminate foods, they're done, they stay on that diet. And this can happen for a few reasons. In some cases, we see patients who experience a strong symptom improvement on the elimination and then become hesitant or even fearful to reincorporate foods into their diet. In other cases, some patients stay on the elimination phase long-term despite unclear benefit on their symptoms, simply because they think that they should be following that diet pattern. And in all of these instances, it's essential to encourage the patient to move through the final phases of the protocol to liberalize their diet as much as possible. Now I'll talk about a few of the common types of food sensitivities and intolerances, including lactose intolerance, A1 beta-casein intolerance, FODMAP intolerances, non-celiac wheat sensitivity, and sucrase isomaltase deficiency. So lactose intolerance describes GI symptoms that are caused by the osmotic load and fermentative processes that occur with lactose malabsorption. And this is a dose-dependent response for patients. The estimated prevalence of lactose malabsorption in the US is about 36%, Although notably not all patients who experience lactose malabsorption will actually experience symptoms of lactose intolerance. And interestingly, in samples of patients with IBS, it's been shown that lactose intolerance, but not lactose malabsorption, is more common compared to healthy patients. And one possible reason for this could be the visceral hypersensitivity that's commonly seen in IBS, which can increase the awareness of and the sensitivity to those digestive sensations that might occur with lactose malabsorption. The treatment approach for lactose intolerance would be a low lactose diet or the use of lactase enzymes. And as you can see here, lactose content of foods varies widely, ranging from about 12 grams in milk and traditional yogurts to 3 to 4 grams in Greek yogurt, ice cream, and soft cheeses, to less than 1 gram in hard and semi-soft cheeses, and virtually no lactose in butter and lactose-free products. And so many patients with lactose intolerance can tolerate many of these lower lactose foods, and therefore don't need to be on a fully dairy-free diet. If a patient is having symptoms even with lactose-free products, another possible contributor to their symptoms could be A1 beta casein intolerance. And A1 beta caseins are a specific type of protein found in milk produced by European origin cattle. Studies have shown that milk containing A1 beta caseins is associated with increased GI symptoms in both lactose tolerant and lactose intolerant subjects. And there have been some associations with slower transit for patients consuming A1 beta caseins. So this could be a possible contributor to constipation in some patients, whereas with lactose intolerance, we would be more expecting to see diarrhea. There isn't a good estimate for the prevalence of A1 beta casein tolerance, but in a patient where this is suspected, the treatment approach would be to limit or avoid A1 beta caseins. So as you can see here, most products made from cow's milk in the US and Europe contain A1 beta caseins in addition to A2 beta caseins. For patients who have A1 beta casein intolerance, the more suitable options would be those containing A2 beta caseins only, and that would include A2 cow's milk, which is produced from herds that are specifically selectively bred to produce A2 beta casein proteins only in their milk, as well as goat's milk and sheep's milk products. So FODMAP intolerance describes a poor absorption to one or more of the types of high FODMAP carbohydrates, and one of those carbohydrates is lactose. Again, this is a dose-dependent response, and the tolerance to different types of FODMAPs varies across individuals, which is why it's essential to complete the reintroduction phase and determine individual tolerances to each of the FODMAP categories. The treatment approach for low FODMAP diet would be a full 3-phase elimination and reintroduction approach, which has been shown to improve symptoms in 52 to 86% of IBS patients. Another option would be a FODMAP gentle approach, which restricts just a handful of more targeted FODMAPs based on the individual symptom history. And this can be a great option for patients who have very high anxiety, active disordered eating, or overall a poor ability to implement the full low FODMAP diet with their lifestyle. Another supportive measure is digestive enzyme supplements, including lactase to target lactose, alpha-galactosidase to target galacto-oligosaccharides, and fructan hydrolase and inulinase to target fructans. You'll see here an overview of some of the more common FODMAPs by category. This is not at all an exhaustive list, but these are some of the more concentrated sources of FODMAPs in the diet. And research on reintroduction protocols has found that the most common FODMAP triggers for patients include milk, onion, garlic, and wheat, as well as high mannitol foods like cauliflower and mushrooms. And then following that would be the high GOS foods, which includes legumes, cashews, and pistachios. An example of a food sensitivity is non-celiac wheat sensitivity. And this can cause both GI and extraintestinal symptoms in response to the ingestion of wheat. To make a diagnosis, wheat allergy and celiac disease would both need to be excluded. And it is recommended to use a low FODMAP gluten-containing test food to challenge wheat after a period of wheat elimination. For a patient with confirmed non-celiac wheat sensitivity, the treatment approach would be a gluten-free diet. And a useful tool in clinical practice to differentiate between non-celiac wheat sensitivity and intolerances to the high FODMAP carbohydrate fructan, which is found in wheat, would be a sourdough bread challenge. And specifically, you would want to use a slow leaven sourdough bread because during that slow leavening process, the bacteria in the sourdough starter break down much of the fructan in the bread, yielding a low fructan, high gluten bread product. If the patient shows good tolerance with the slow leaven sourdough, but poor tolerance to other types of wheat products, then this would indicate a likely fructan intolerance. Whereas if the patient's noticing symptoms with all wheat products, including slow leaven sourdough, this would be more likely non-celiac wheat sensitivity or celiac disease. And last, I'll touch briefly on sucrase isomaltase deficiency. And so this describes intolerance to sucrose in starch that can arise due to a deficiency of the enzyme sucrase isomaltase. Studies in IBS patients have found an increased frequency of sucrase isomaltase gene variants, specifically in IBS-D patients, which suggests that in some cases, sucrase isomaltase deficiency might actually be misdiagnosed as IBS or might be an overlapping contributor to symptoms. And unlike some of the other food intolerances that I've discussed, which are diagnosed through elimination and reintroduction protocols, sucrase isomaltase deficiency does have some test methods available, including disaccharidase biopsies or breath testing, although increasingly insurance payers are requiring biopsies in order to cover enzyme therapy. And that brings me to the primary treatment approach, which would be the use of saccharosydase enzymes. Those are available by prescription. Another option would be a low sucrose, low starch diet, although this is typically only recommended when the patient either doesn't have access to enzyme therapy or is having an incomplete symptom response. So a few take-home points here before I wrap up. One, the vast majority of patients with IBS have at least one food intolerance or sensitivity. So this is extremely common in this patient population and is something that comes up often in clinic. Two, elimination and reintroduction protocols are the gold standard for diagnosing most food sensitivities and intolerances, and there's inadequate evidence for the use of food sensitivity testing in clinical practice at this time. And third, a nuanced understanding of food sensitivities and intolerances can aid with diet liberalization. So for example, many of our patients with lactose intolerance present to clinic on a fully dairy-free diet when there are likely some lower lactose and lactose-free products that they could incorporate. And with FODMAPs, because there is a wide variance of tolerance to different types of FODMAPs and quantities of FODMAPs, most patients can reintroduce some FODMAPs back into their diet during the reintroduction phase. Here are a few additional references for the slides that had charts on them. So these are available in the slide deck. And thank you all so much.
Thanks. We're going to hold questions except for Dr. Drossman. So I just want to remind you, if you have the index cards there, if you want to write notes, Tricia James will bring them up to us and then we can answer them during the Q&A. So our next speaker is Andrea Shin.
Okay. So I want to thank the symposium organizers for inviting me to participate in today's conference. I'm going to move on and build on Dr. Mint's case and some of the information that was provided to us by Kate Evans and talk about just brief overview of diagnosis. I think Dr. Mint covered that really well, but really focus on management. So objectives over the next 20 minutes will be to provide a brief overview of diagnosis of chronic diarrhea, and this can include syndromes such as functional diarrhea and irritable bowel syndrome. But we'll focus mostly on reviewing therapeutic strategies and how this applies to functional diarrhea or IBS-D, highlight pharmacological treatment options, and then finish up by summarizing what we know. All right, so I just included this to show the diagnostic algorithm for patients who present with symptoms of chronic diarrhea are pretty similar across the board if you look at guidelines that are published through the various societies, including in the United States and other countries. This is the diagnostic algorithm supported by the European guidelines. And like Dr. Mint, as he walked us through, evaluation and testing, again, it really is founded on establishing a good clinical history and a limited repertoire of laboratory testing. And if we are familiar with the clinical features and the signs and symptoms, we should be able to make a pretty confident diagnosis of either functional diarrhea or IBS with diarrhea. This is the clinical decision support tool that's available through the AGA website. This is the tool to guide clinicians for patients who are presenting with symptoms of chronic diarrhea. And as Dr. Mint had summarized really nicely in his case earlier, again, detailed history, screen for alarm symptoms, and then consistently evaluating for alternative conditions such as celiac disease, inflammatory bowel disease, infection if there are risk factors. And then being able to make that diagnosis so that we can move on to then effectively offering therapies and management. So for a management perspective, we do have to acknowledge that there really are few studies that have looked at functional diarrhea specifically as a distinct entity from IBS with diarrhea. But we do try to tailor our treatment approach based on symptoms, symptom types, and symptom severity. We'll focus on lifestyle modifications, diet-based therapies that were covered by Kate Evans so nicely. And then there are a variety of pharmacological agents that are available and brain-gut behavior therapies. What we know in functional diarrhea is largely extrapolated from the IBS-D literature, but I wanted to walk through that in the next several slides here. Okay, just briefly touching on diet therapies, I think Kate did a really extensive job in this, so I don't think that we have to go into this in too much detail, but diet-based guidance is often a cornerstone of management for patients who present with symptoms of functional diarrhea or IBS with diarrhea. So it is important for us as clinicians to be familiar with this. A lot of patients with IBS or functional diarrhea will report meal-related symptoms, symptoms that are triggered by food, or postprandial symptoms. Now, there is quite a bit of evidence, and I'll review this in terms of the data that we have about diet-based therapies. There's quite a bit of evidence regarding the role of the low FODMAP diet, particularly in irritable bowel syndrome. So a little over 10 years ago, Heidi Staudacher and colleagues published this really nice RCT comparing the low FODMAP diet to a habitual diet. And they did demonstrate that the low FODMAP diet was associated with higher response rates in participants compared to habitual diets. But then subsequent to that, there were a number of other clinical trials that showed some inconsistent results regarding the efficacy of a low FODMAP diet in comparison to other dietary strategies. And there have been some theoretical concerns raised about the long-term safety of a low FODMAP diet or the nutritional adequacy. And this is one of the reasons why ensuring that we're following a proper protocol and reintroducing foods where necessary is so important. This is a forest plot from a systematic review and network meta-analysis that was published by Christopher Black and colleagues a couple of years ago. And in the systematic review, they compared across different diet trials the effect of a low FODMAP diet and other dietary interventions for irritable bowel syndrome. They also restricted the analyses to patients with IBS with diarrhea as well. And in general, they did observe that the low FODMAP diet seemed to have the best benefit for global symptoms, pain, and bloating, but not necessarily for bowel habits. And this might be important to us, particularly if we're dealing with a patient who may have functional diarrhea and not necessarily IBS with diarrhea. In terms of the IBS group, again, the systematic review did suggest that the low FODMAP diet was superior to placebo and possibly superior to the other treatments as well, although the differences were not always statistically significant for the individual symptoms. Now, I think since functional diarrhea is, again, part of this continuum with IBS-D, it is important to think about the role of diet management in functional diarrhea, regardless of whether or not they may also have symptoms suggestive of irritable bowel syndrome. This was a smaller study that was published recently that I thought was clinically relevant. And this is a study that compared the effect of a low FODMAP diet to psyllium supplementation for patients with fecal incontinence and loose stools. And their primary endpoint was reduction in fecal incontinence episodes. And in this study, they didn't show a statistically significant difference between the two interventions. Within each intervention, the low FODMAP diet was associated with an improvement in stool form as well as improvement in fecal incontinence quality of life scores. But similar findings were also shown in the psyllium arm with reduction in fecal incontinence episodes and an improvement in quality of life. So findings from this study didn't necessarily suggest that one diet-based approach was better than the other, but did provide evidence suggesting that there is a possible role for the low FODMAP diet or possibly even soluble fiber for management of chronic diarrhea or fecal incontinence. Gluten, this is, again, this was covered very well by Kate. I just want to summarize this by saying there have been a few randomized trials suggesting possible benefit with gluten-free diet in patients with irritable bowel syndromes, but recent data that have tried to pool the results haven't shown statistically significant differences. And so based on the current literature that is available, generally we don't feel that there is sufficient evidence to recommend a strict gluten-free diet for patients with irritable bowel syndrome. Moving on to pharmacological treatment. So there are a variety of pharmacological agents that are available for the treatment of chronic diarrhea, particularly IBS with diarrhea and functional diarrhea. And again, we are extrapolating some of this from the IBSD literature to management of patients with functional diarrhea. Loperamide, most of us are pretty familiar with this. So loperamide, the data for loperamide is mostly available from older studies that were published back in the 1980s. It is a peripheral synthetic opioid agonist. It can reduce peristalsis, has anti-secretory effects, and has been shown in these older studies to improve stool frequency, stool consistency, pain, and urgency. More recently, investigators have attempted to pool these results and conduct some updated analyses, and these data haven't shown clear evidence for benefit for overall or global IBS symptoms. So for this reason, if you look at the different guidelines, you may see some different recommendations. The European guidelines and the AGA guidelines take a more symptom-based recommendation, and they do recommend or support the use of loperamide for the treatment of IBSD. Focusing mostly on the treatment of the diarrhea, the GI symptoms. The ACG doesn't recommend it because their guidelines focus more on IBS in terms of the composite endpoint or the global symptoms of IBS. But loperamide is often a first-line strategy that we'll use for management of chronic diarrhea, such as functional diarrhea or IBS with diarrhea. Elaxadiline, this is a mixed opioid receptor agonist-antagonist. These are data from 2 phase 3 placebo-controlled trials. The primary endpoint was the composite FDA responder endpoint, which was a decrease in pain as well as an improvement in stool consistency. And results of these studies did demonstrate superiority of elaxadiline compared to placebo. Pancreatitis did develop in a very minor percentage of the safety population, and so remember, it is contraindicated in people who have a history of pancreatitis, prior history of alcoholism, or if they have a history of consuming more than 3 alcoholic beverages per day. Both the AGA and the ACG do support the use of elaxadiline for the treatment of IBSD, and there are no available data for patients specifically with functional diarrhea. Bile acid modulation, I do want to bring this up. So bile acid malabsorption is considered a common mechanistic phenotype of functional diarrhea or IBS with diarrhea. There are 3 types of bile acid malabsorption. There is the type 1 that we classically correlate with ileal disease, intestinal resection, or perhaps inflammatory bowel disease that has affected the terminal ileum. There's the type 3 bile acid malabsorption, which is considered to be the bile acid malabsorption that occurs secondary to an alternative cause, like bacterial overgrowth or pancreatic insufficiency. When we're talking about bile acid malabsorption in functional diarrhea or IBS, we're talking about type 2, which is the primary or the idiopathic bile acid malabsorption. And there has been quite a bit of literature gathered throughout the years demonstrating that bile acid malabsorption is very common, occurring in up to a quarter to a third of patients who present with lower functional bowel disorders, including irritable bowel syndrome and functional diarrhea. And these are two, an older review and a newer review showing, again, consistent results over the years. What about bile acid binders for the treatment of functional diarrhea or IBS? While there's a lack of controlled trials that have looked specifically at the efficacy of bile acid sequestrants in the treatment of IBS, but there are clinical studies that have examined the effect of bile acid modulation on individual symptoms. This was a study that, an open label study looking at colesevelam in patients with IBSD, and the data from this study did show that it increases delivery of total fecal bile acids to the stool and led to an improvement in stool consistency. A phase 4 RCT of colesevelam that was conducted in Europe also demonstrated that when patients present with symptoms of a bile acid diarrhea, or these are patients who actually presented for diagnostic testing, that treatment with a bile acid binder was superior to placebo. And based on these data, both the AGA and the European guidelines do suggest that it is reasonable to consider the use of a bile acid binder for patients who may be suspected to have bile acid diarrhea or may have persistent chronic diarrhea. And again, the ACG doesn't support the use of bile acid binders in their guidelines because, again, they're framing their recommendations on overall IBS response endpoints. Rifaximin, most of us are pretty familiar with this. The data were acquired from the Target 1 and 2 trials, which demonstrated that rifaximin is associated with a significant relief in IBS symptoms, bloating, pain, and in bowel functions. And it can be repeated up to 2 times. This is based on the retreatment trial data and has a very favorable safety profile. I included one of the figures from the secondary endpoints from the Target 1 and 2 trials, which also show that rifaximin was associated with improvements in stool consistency. But again, because these trials were conducted in IBSD, rifaximin is approved for the treatment of IBSD and is supported by both the ACG and the AGA. There's limited evidence, direct evidence in patients with functional diarrhea, but based on the secondary endpoint data, we may extend some of these observations to suggest that rifaximin could have beneficial effects on bowel function as well. Olocitron is a 5-HT3 antagonist, and it's shown to be effective for pain, diarrhea, and urgency, approved for women with severe IBSD. It no longer requires the risk evaluation and mitigation strategy. Remember, we start at 0.5 milligrams twice a day, and you can decrease this or increase this depending on a patient's response. Olocitron is supported by both the AGA and the ACG for treatment of IBSD, but there is no direct evidence for efficacy of olocitron in functional diarrhea alone. Ondansetron is really interesting. So ondansetron was actually the first 5-HT3 antagonist that was studied in functional bowel disorders, and this is based on older data published in the 90s. And recently, there have been attempts to look at the efficacy of ondansetron in IBS with diarrhea. A couple of years ago, Plass and colleagues published this paper that of a study involving approximately 200 patients or so, where they randomized patients to bimodal ondansetron. And the primary endpoint was improvement in stool consistency, and they did show a significant benefit with ondansetron treatment. Subsequent to this, there was an attempt to initiate a very large 12-week randomized controlled trial where the primary endpoint would be the FDA responder endpoint for IBS. Unfortunately, because of the COVID-19 pandemic, only 800 of the projected 400 participants were recruited, and there was no significant difference with respect to the primary endpoint. But, however, they did note improvements in stool consistency. And this is actually consistent with the findings that were published by Plass and colleagues, as well as the older data published back in the 90s. When they pulled their results with other trials that had been conducted using ondansetron, it was demonstrated that ondansetron was superior to placebo for all endpoints except for pain. So interestingly, while there's no direct evidence for benefit of ondansetron in functional diarrhea, most of the endpoints or the differences that have been observed in these trials suggest that the biggest effect may be on symptoms of diarrhea or bowel function. What about antispasmodics? These are a pharmacologically diverse class of agents. They have varying mechanisms of action. In the United States, we have hyoscyamine, dicyclamine, and peppermint oil available. This is a forest plot from a systematic review and meta-analysis that looked at the efficacy of peppermint oil, and it's generally been demonstrated that peppermint oil seems to have a significant benefit for global symptoms in IBS. There has been a Cochrane review that was also conducted on the use of antispasmodics broadly, and the data from this review suggested that antispasmodics may be beneficial for global symptoms as well as pain. However, there were a limited number of studies within individual antispasmodic categories. And so in general, the literature is considered to be very heterogeneous. And so we do see slightly different recommendations from the AGA and the ACG. The AGA does recommend the use of antispasmodics, while the ACG suggests the use of peppermint oil specifically. Again, no direct evidence for efficacy of antispasmodics in treatment of functional diarrhea alone. The last class I want to focus on are the tricyclic antidepressants. These are neuromodulators that can improve visceral and central pain. It can affect GI motility in transit and intestinal secretion. TCAs are associated with improvement in global symptoms and abdominal pain. Most trials have included multiple IBS subtypes. And so based on these data, both the AGA and the ACG support the use of tricyclics in irritable bowel syndrome. While there's no evidence for TCAs in terms of functional diarrhea, there are some older studies that have examined the effect of TCAs on bowel functions. The figure there on the right is from a smaller study examining the role of amitriptyline in patients presenting with fecal incontinence. And interestingly, they did demonstrate that amitriptyline was associated with a decrease in fecal incontinence episodes as well as an increase in colonic transit time. Probiotics, I think this is a question that a lot of us get. So just to kind of summarize the literature, in a fairly recent systematic review and meta-analysis, Ford and colleagues did demonstrate that there seems to be possible benefit for global symptoms and pain with the use of probiotics. But in terms of trying to discern which probiotic, which strain, which combination, there just isn't enough literature or enough data out there to guide clinicians or guide patients. There have been more recent individual studies that have suggested that probiotics can be beneficial for pain and symptoms and bowel habits. But again, the specific formulations are highly varied, and most of these have been conducted using different study designs and among multiple IBS subtypes. So based on the existing evidence, neither the AGA nor the ACG specifically recommend the use of probiotics, mostly because we just don't have enough knowledge in this field. And then lastly, psychosocial and behavioral treatments. It is largely recognized that these treatments have a role for management in IBS. This was a systematic review and network meta-analysis conducted again by Christopher Black and colleagues that demonstrated that most psychological therapies appear to be superior to control therapies in treatment of overall IBS symptoms. There wasn't one particular therapy that emerged as being superior to the others, but the largest evidence base exists for cognitive behavioral therapy and hypnosis. So just to kind of summarize what we talked about, there are a number of management approaches that we can use for treatment of functional diarrhea and treatment of IBS with diarrhea. Again, we have to tailor our treatment selection depending on the predominant symptoms. The treatments there on the left are generally the treatments that have some evidence supporting their use in the literature. The treatments on the right, which I haven't covered in today's talk, generally we don't recommend the use of these strategies in management of functional diarrhea or IBSD. So remember, management is founded on diet, lifestyle, and medications, behavioral therapies. We have a lot of treatments available for IBS, and we use this data to sometimes extrapolate to patients with functional diarrhea. And our treatment selection is still largely guided by symptoms. And we have a limited number of clinical trials that have actually looked at combined therapies or comparative effectiveness. And in the future, hopefully, the goal would be to be able to develop better individualized treatment plans that can be based on novel tools that could help us key on specific pathophysiological mechanisms that may be more relevant to one individual over another.
Thank you. Thanks so much, Andrea. So this is our first panel discussion. I took the liberty to just come up with some questions in case there wasn't many questions from the audience. So these are just some of the thoughts. And you saw a lot of the evidence, and I would like our discussion to also be more practical too, and what we do in practice. But we do have one question from the audience, and Kate, I'm gonna have you take this one. Is there evidence for a low histamine diet in this patient population? There may be just in general, but what would it be helpful for?
Yeah, so the low histamine diet has a limited amount of evidence. There is a potential role of histamine in certain conditions, including mast cell activation syndrome and potentially in IBS, but more research is needed to better understand its role. And one of the main practical challenges with the low histamine diet is that we don't have a lot of good evidence to really support any one list of high or low histamine lists to use in the same way that we do for, let's say, low FODMAP diet. For low histamine diet, it's tricky to pinpoint how much histamine a given food contains because histamine content changes over time. It can change regionally. Leftovers might have higher histamine content than the food in its freshest form. Cooking method can impact histamine, and there overall isn't a large source of data for which foods are highest in histamine. So a lot of the lists that exist out there on the low histamine diet are based on, the limited data that exists and more of a hunch or a guess as to which foods might contain more histamine. So in general, low histamine diet is not something that I often recommend in practice in very specific situations where the patient has a known history of mast cell activation syndrome or other non-GI symptoms that would be more consistent with a histamine intolerance, such as facial flushing and other skin symptoms, breathing symptoms. It may be a consideration, but it's definitely not high up on the list of things that I would consider with IBS.
Okay, thank you. I'm going to ask you another diet question, a diet-related question that maybe you can answer briefly for the audience. I know that dietitians use some of these supplements, these enzymes, and I've started incorporating. I know there's not good quality, randomized controlled trials, but you mentioned a few of them. Can you just tell us, like practically, which one would you suggest in which patients?
Yeah, so I think enzymes can be a great option, especially if patients have less ability to modify their diet, if they're eating in an environment where they don't have as much control over which foods they're consuming. It can be harder to do a diet intervention, and that's where enzymes can come in. The other situation that can be very helpful is if a patient has known intolerances. Let's say they've gone through the 3-phase low FODMAP diet, they've identified a few specific triggers. Some of those triggers may be better tolerated with a digestive enzyme supplement. And the most evidence-based options currently would be lactase to target lactose, and then alpha-galactosidase to target galacto-oligosaccharides. So that would be found in like legumes and certain nuts like cashews and pistachios. There is some evidence in IBS for that enzyme specifically as well. And there are some newer enzyme products in the market that incorporate an enzyme called fructan hydrolase, or enzymes referred to as inulinases as a class, and these are designed to target fructans. There is still pretty limited evidence here. There's one company that makes fructan hydrolase and has some in-house research, but not a lot of published literature yet. And there are some in vitro studies with inulinase targeting fructan. So some early research there, and I think it's worth a try in patients who have a known fructan intolerance.
Okay, so I want to get to this first question because we get this a lot. So Andrea, and if others want to chime in, patients will often bring us these, heat maps of these food panels and the microbiome tests, and they give it to you and they ask, okay, now what I should do. What's the evidence, Andrea, and what do you say to the patient? How do you address it?
I usually say that a lot of the tests that are available commercially for patients right now are probably based on very preliminary research, and so they're not yet clinically validated to give us rational guidance. And so I try to acknowledge that, there is some merit in these concepts, but I don't use them to specifically design an approach to treatment for
one particular person.
I want to bring up another point related to this, which is that patients come to us who are overly restricting. The only thing patients know what to do to control their symptoms is to restrict food, and they get onto it, and they come in, they're off gluten, and you can tell them, look, you're still having symptoms while you're on the gluten. But I think it's very important for the dietitian, and Kate alluded to this, is that they have to help re-educate these patients to get them back on their diet. Because I think that's as big as a problem as us trying to find the sensitivities.
Yeah, I mean, these symptoms are very unpredictable. So patients will have, they'll eat, like say, spaghetti one day, and they'll say, I have terrible symptoms, and another day they're fine. But then they decide to restrict it anyways. And then you'll even say, are you better, or did it make a difference? No, I don't know, or I'm not really, but they still restrict it. So that's some of the, the issue that has to help with re-education about it. But I want to talk about now a little more treatment that's not maybe dietary, but how would you approach, and I'm going to go to Tony, and you've seen this patient. So we have a patient with chronic diarrhea. This patient that you presented had more pain with diarrhea, so it was more IBS diarrhea than functional or chronic diarrhea. So what do you think, how would you approach that, the patient?
So I guess just sort of thinking broadly, whenever I get a DGBI patient in your clinic, I try to think about what the predominant symptom is. So obviously we talked about this patient having a lot of pain, and that actually helps narrow your treatment options quite a bit. So for me, I try to think of the centrally mediated pain options and then the peripherally mediated ones. That's probably an oversimplification of the physiology, but it helps me at least from a practical standpoint. So the central ones would be things like neuromodulators, like a tricyclic, or an SNRI, and then potentially some brain-gut behavioral therapies as well, if there's a really strong biopsychosocial component to their symptoms, because oftentimes the emotional response and the cognitive response to pain or symptoms can actually influence the descending pain modulating pathways and augment the pain that they're feeling. And as Dr. Shin had talked about quite extensively, there's a lot of good data to show that those are beneficial interventions. And then I think actually for this patient, we talked about a TCA for her because there's sort of the fortunate benefit of also a constipating effect, and she had IBS-D, but I think she ended up not wanting to pursue that route. So instead we pivoted to the peripheral therapies, which we talked about quite a bit. And for her, I think we ended up going forward with an antispasmodic, mainly because, I think her symptoms were predominantly rectal urgency. I think I oversold a little bit about the diarrhea story, but in reality, I think the rectal urgency was the biggest complaint for her. So we ended up going forward with, I think, an encapsulated peppermint. And because a lot of her symptoms were postprandial, we actually ended up having her time it preprandially to help with that. And so that then, I think we saw her again fairly recently, and after she had that experience and had this sort of contingency plan, her ability to sort of go out and live her life more freely improved quite a bit. Not just from a symptom standpoint, but also from like a anticipatory anxiety standpoint, because she felt like she had at least a backup plan if her symptoms came on. Obviously, if she didn't respond to that, then we would be going down to the more I think, unique medications like rifaximin or iloxadeline. I don't recall if she had her gallbladder taken out or episode of pancreatitis, but I don't believe so. So that would have been a reasonable option. And then, a third-line agent like elocitron, if neither of those things helped either.
Yeah, we have first of all, you sound like an expert. So
I'm just regurgitating what you told me yesterday.
You're listening. That's good. Okay, so I think, a lot of times you have to talk to the patient too. So we may have thought we'd want to use a tricyclic, chronic symptoms, it would be better off. But many times patients don't want to do that. So you phase it in. They're more open to starting like an antispasmodic peppermint oil, even though you wouldn't necessarily use the antispasmodic for chronic pain. But, if the patient is more comfortable, we can do that, and then they can learn more about their symptoms, also dietary treatment. And luckily, we have a GI psychology team for any stress-induced or symptom-related anxiety. Doug, do you have thoughts about how you would treat this patient?
Yeah, I'm seeing this patient not so much dietary because FODMAP didn't work. There's no nocturnal diarrhea. This is a patient who has increased reactivity to food, filling the stomach, increased gastrocolic reflex. That could be playing a role. Antispasmodic would be good with that. And also, I'm seeing this hypervigilance, this anticipatory anxiety, as you saw. I think this is someone who I'd definitely send for CBT because it's affecting her life. Was it male or female?
It's a woman.
Woman, affecting her life in terms of cutting back on activities and things like that. The other thing that interests me in terms of the visceral hypersensitivity component is there's a lot of attribution in terms of rectal urgency. And I know she had ARM before, but I would be interested in looking at balloon sensitivity testing to see if she has rectal hypersensitivity and whether that could be amenable to balloon sensory training as well, in addition to treating the visceral hypersensitivity with the tricyclic.
Yeah, that's a whole different conversation because if you do balloon sensitivity, if you're not doing it in research, you have to do it anal rectal manometry, which means you need the indication, and the balloon distension protocol is really volume-based, not pressure-based, which, yeah, so we've had that discussion. So I don't personally think it gives you a great view of rectal perception, but it is important. I think a lot of times if you just improve their diarrhea, they have less urgency. And that helps. I want to get to bile acid diarrhea, and I was Andrea. I know that you've thought about this a lot. Who are the patients that you would think about giving them a bile acid sequestration, and how do you use it? Because you probably start lower, and then you would increase it. So what instructions do you give the patient if you're going to approach it that way?
So people that I might think about using a bile acid binder will be people who have almost more of like a secretory type of diarrhea where they have a lot of urgency, maybe even some nocturnal symptoms, and we know they're struggling. Like we've made a diagnosis of functional diarrhea or IBS with diarrhea. So the colesevelam studies studied a dose of 1,875 milligrams twice a day, which is technically 3 tablets twice a day. It's a pretty high dose. I don't usually start that high. I'll usually give them that prescription, but I'll have them start with like 1 tablet twice a day and see how they respond and go up if they need.
How fast do you tell them to go up?
I'll usually have them do it for a couple of weeks at least. I think that's usually enough time to see if they'll respond well. And the side effect is that it can be constipating. So you don't want to go too fast and then potentially flip them to the other side. And then they have it in their head that they don't want to use bile acid binders.
Yeah. What do you think about, because I think Mike Camilleri had a study that showed that people who had more severe symptoms, the urgency, more likely have had a cholecystectomy, that they would have bile acid diarrhea. Do you think about that a lot? Because some patients who had a cholecystectomy, they will have loose stools for a while, and then their GI tract will acclimate and it will go away. How do you deal with that?
With the cholecystectomy part of it, I take into consideration like how long ago their cholecystectomy was, because yes, you'll usually counsel patients pre-cholecystectomy that they may have diarrhea for several months or so, but hopefully their body will readjust. In the studies that came from Michael Camilleri's group, when they marked out the people who had cholecystectomy and had bile acid diarrhea, they didn't necessarily see cholecystectomy as a risk factor for idiopathic bile acid diarrhea in their populations of IBS with diarrhea. But I definitely ask about it, and I think about that as a possible contributor.
Yeah. So Rachel, you've been in clinic for a while. You've been studying this area, and I think really an important component, a point that we should think about when we say patients, we think, gosh, they seem kind of anxious. Maybe they have general anxiety, but some of the patients really don't have general anxiety. They have symptom-related anxiety, and your approach could be different. So how do you assess that when you see the patients?
Yeah, thank you for the question. I think I usually ask the patients, when do you experience the anxiety and in what circumstance does the anxiety come on? And I also ask about when their anxiety started in their life. So there are some patients who know that this is the time when my disorder of gut-brain interaction started, and before that I had long-standing anxiety, or I noticed my anxiety started after I developed these symptoms, and I developed anxiety around finding toilets as close to me as possible when I went somewhere. And sometimes that timeline can be helpful, that it might be symptom-related anxiety if the anxiety came after the onset of symptoms, and also situationally, if they feel more anxious when their symptoms are more intense, that might lead me to believe that they have symptom-related anxiety rather than generalized.
Yeah, and if you could reduce their symptom, the symptom burden, then their anxiety could get better. Doug, did you want to make a comment?
Just to reflect on another point, you mentioned before that the patient doesn't want to go on a tricyclic. You start with an antispasmodic. I think it's also good to begin the dialogue at that point to say that the tricyclics are helpful in terms of the visceral hypersensitivity.
Yeah.
We can go with the antispasmodic, but we have another option. I think you need to get into their head so you could revisit that rather than do it when the other one fails.
Oh, no, definitely. I definitely think that when you see a patient, you should give them the options. And as you've taught many times, it's a shared decision-making of what they're comfortable with. But they definitely should know the options, and that's when they can make a more informed decision. So it's a good point. Okay, we need to move to our next part. Rachel Sarnoff is going to present the next case.
I'm very happy to be here. As Dr. Chang mentioned, I'm Rachel Sarnoff, and I am honored to present a case today, which is epigastric abdominal pain in a young man with anxiety. So we have Mr. E, who is a 27-year-old man with a history of anxiety, who presented to us with 9 years of upper abdominal pain. He says that he's had intermittent upper abdominal pain on a daily basis that comes on in between his meals, and he feels a dull and gnawing pain that spreads out from his upper abdomen. He says that his symptoms started 9 years ago when he ate a lot of spicy meals while traveling internationally after graduating from college, and then his symptoms began out of the blue, and unfortunately, they've only worsened since. He notes that the longer he waits in between his meals, the worse the pain gets, and he notes that this pain is his most bothersome symptom and really is affecting his quality of life. He notes that feeling anxious, which he does from time to time given his generalist anxiety disorder, is also a trigger for his pain, and when he used to have more frequent panic attacks, the panic attacks would bring on the pain as well. His abdominal pain is not related to bowel movements. And he also notes separately that he has noticed with spicy or heavy foods in his meals, he will sometimes feel bloating, which started on a similar timeline to the epigastric pain, but is not his predominant symptom. He was diagnosed with H. pylori early in his symptom course, but unfortunately, eradication did not improve his symptoms. And on review of systems, he denies any difficulty or pain with swallowing, weight loss, bloody or melenic stool, early satiety or fullness, nausea, or vomiting. He was diagnosed with SIBO early in his course as well, and was given a course of rifaximin, which actually significantly improved his symptoms. He found he could go longer between meals without experiencing the pain. But unfortunately, after some time, the pain returned in full force, and further courses of rifaximin were not effective. In terms of treatments, he was briefly taking omeprazole at the start of his symptoms, which was ineffective. And also of note, encapsulated peppermint as well as hyoscyamine as needed was helpful for that postprandial bloating that he got with spicy foods, but it was not effective for his epigastric pain. We'll only review notable items from the rest of his history. So in terms of past medical history, we briefly touched on his history of anxiety with panic attacks. This was long-standing prior to the GI symptom onset, and he's been plugged in with therapy and psychiatry for some time, and his symptoms he feels are much better controlled than before. He also has a history of mid and lower back pain. And in terms of family history, this is notable for multiple members of his mom's side of the family having serious mental issues, including depression, bipolar, and suicide, with his mother having depression. In terms of medications, he's on low-dose escitalopram and propranolol. These are for his anxiety, as-needed lorazepam for his panic attacks, and as-needed encapsulated peppermint and hyoscyamine, as we discussed. His social history is only notable for he is a film editor who works at home for a management company, and he lives with his girlfriend. His physical exam was very much unremarkable, with normal vital signs, a normal affect, and a non-tender, non-distended abdomen. In terms of his labs, he had a recent blood count and metabolic panel that were normal, a negative H. pylori stool test, a normal right upper quadrant ultrasound, and way back at the start of his symptoms, he had that endoscopy that showed H. pylori gastritis that was treated. and the duodenal biopsies were normal. He had a colonoscopy at the same time, which was normal, with normal biopsies. So now I'd like to take a step back and just talk about the definition of dyspepsia. Dyspepsia is defined as any of the following: pain or burning in the upper abdomen, early satiety, and or discomfort after meals. And it has quite a large differential diagnosis, including gastroesophageal reflux disease, functional dyspepsia, which we will be touching on, IBS, peptic ulcer disease, various types of gastritis, chronic pancreatitis, biliary pathologies, upper intestinal cancers, and medications. And the demographics, history, and physical can help increase or lower our suspicions for each of these differential items. So I would like to present an algorithm which I put together drawing from both the Rome Foundation guidelines for working up dyspepsia as well as up to date. And I hope that this can provide a streamlined approach to a patient who has uninvestigated dyspepsia. So the first fork in the road is based on age. We care about patients who are greater than or equal to 60 years old in that it changes our approach because we immediately proceed with endoscopy. The reason for this is because the elderly age group has a higher incidence of upper intestinal cancers that are not to miss diagnoses. In the younger age group, less than 60, we perform endoscopy in patients who have certain clinical features that raise cause for alarm proceeding with endoscopy. These include clinically significant weight loss, overt gastrointestinal bleeding, greater than one alarm symptom or rapidly progressive alarm symptoms, where alarm symptoms are unintentional weight loss of any kind, dysphagia, odynophagia, unexplained iron deficiency anemia, persistent vomiting, palpable masses or lymph nodes, or a family history of upper intestinal GI cancer. I will note that our patient did not have any of these clinical features, but he did have an endoscopy performed, and this is probably because of how severe his symptoms were at the onset and how he had daily symptoms as well. So the early provider decided to perform one. If endoscopy is indicated, we go ahead with endoscopy. And at this point in time, we also consider abdominal imaging in patients for whom you have increased suspicion for some of those other elements of the differential diagnosis, like biliary pathology, depending on their symptom pattern and demographic. In the case that we do not find endoscopy warranted in the younger age group, we test for H. pylori with stool or breath test. And if the H. pylori is positive, we of course treat the H. pylori. However, if the symptoms persist, as is the case in our patient, we have now arrived at the possible diagnosis of functional dyspepsia if the patient meets criteria, which we will go over in a minute. If the patient has negative H. pylori, we proceed with the diagnosis of functional dyspepsia as well. And anyone who receives an endoscopy, of course, we would treat the organic disease if we find one to be present on that or on imaging. However, if organic disease is absent, again, we have arrived at functional dyspepsia. So now to take a closer look at functional dyspepsia, I'd like to define the criteria. It includes bothersome postprandial fullness, early satiation, epigastric pain, and or epigastric burning, and no structural disease that is likely to explain these symptoms. And we must meet criteria for one of the two subtypes for at least 3 months with symptom onset at least 6 months ago. So the subtypes include 1, epigastric pain syndrome or EPS, which is bothersome epigastric pain or burning impacting activities at least 1 day per week. The other subtype is postprandial distress syndrome or PDS, which is defined by bothersome postprandial fullness and or early satiety that impacts activities or meal completion at least 3 days per week. So reflecting on our patient, Mr. E, he clearly met criteria for functional dyspepsia, the EPS subtype, because he had intermittent epigastric pain between meals on a daily basis for 9 years. However, it's interesting to note that he also had concurrent onset of other manifestations of visceral sensitivity, including increased sensitivity to those spicy or heavy foods with the bloating. And finally, I want to note that he had multiple risk factors for development of disorders of gut-brain interaction, including a personal history of anxiety, family history of mental illness, including in the home, and highly stressful events and illnesses, including his college graduation and the GI symptoms with the spicy foods while he was traveling. Thank you so much, and I'd like to turn it over to Dr. Drossman.
Thank you, Rachel. I just want to focus this session, this case on abdominal pain, because abdominal pain is such an important symptom that drives symptoms, very poor quality of life and healthcare utilization. So that's why it'd be great to have Dr. Drossman speak about the use of neuromodulators to treat chronic abdominal pain of different DGBIs.
A lot to talk about. I only have 25 minutes. Remind me when I'm 5 minutes. There's a lot here. If you are interested, I want to show you a paper that you could go to. You can also go to the Rome Foundation website. There's a grand rounds that Lin Chang and I did on neuromodulators. It's very, very informative, and a lot of what we have to say here is on that. First thing we need to know is that starting in 2016 with Rome 4, we changed the terminology from psychotropics, antidepressants, and all of that. We changed it to neuromodulators. Central, which are the antidepressants, anti-anxiety, and peripheral, which are the everything working on the enteric nervous system, chloride channel agents, delta ligand agents, and the like. It's rational, it's scientifically relevant, and patients are much more accepting of that than being told you're putting them on an antidepressant or an antipsychotic. With Lynn's group, we did a survey to look at the comfort level of doctors in using neuromodulators, central neuromodulators. It's no surprise that the comfort level came up first with tricyclics, a little bit more for SSRIs, which has very little to do with treating abdominal pain, less for SNRIs and anxiolytics, and very little for the antipsychotics. We asked them why they don't treat, and it's no surprise side effects was first, not certain which to prescribe, which is the purpose of this lecture, not comfortable prescribing, worried about patient refusal, and so on. So a big effort now with the Rome Foundation is to try to educate people on the use of these agents. This is the paper, which is a Rome Foundation working team that I'd recommend you look at. It is a few years old, but most of the information has not changed very much. I'll skip the committee process, but we did an evidence-based review, looked at consensus, and made recommendations. We do have a paper, hopefully, which will be accepted. We resubmitted, which gives into more granular details of what you use, how you prescribe, how long you treat, how you cross-taper, and the like. So the rationale for antidepressants is based on 4 premises. One is that there's comorbid psychiatric and brain-gut disorders associated with pain, which can be independently treated. Second is that there are peripheral effects on motility and nerve signaling at the level of the gut. The third is that it improves the brain's pain regulation. And the fourth is that may help enhance neurogenesis and prevent relapse. This is a very old study showing, which you already know, that tricyclics, which are dominant noradrenergic, will slow down orophyseal transit time, or will speed it up, the transit time, or slow down the motility. Conversely, the SSRIs, which have a serotonergic effect, will speed things up, with side effect being diarrhea. There's evidence when you look at signaling at the level of the pelvic floor in the rats that increasing doses of tricyclics shown here are associated with decreasing afferent discharge. So maybe some of the pain is a reduction of the signaling at the level of the gut. Another very important area is the resetting of the dysregulation in the brain's ability to regulate pain when it receives it. This is a slide that came out, another working team by Emerson Myers. And what you're seeing here is that the brain is receiving input in many different ways. The sensory motor network, which is the insula and the sensory cortex, the location and the intensity of the pain. How salient is it? This is the cingulate cortex. How is it dangerous? Is it something I should pay attention to? Then it goes to the executive network. How do you appraise this? Is this scary? Is this something I can do something about? Reappraise it. The emotional arousal network. you become anxious, you become depressed, and then the autonomic system, these people can overreact with changes in blood pressure, you see, or pulse rate, co-association with POTS, and all the other autonomic activity. So patients with these chronic pain syndromes have dysregulation of this control mechanism. And as you can see on the right, it can affect the descending inhibition of incoming signals going up. They have impaired cognitive circuit and affective circuit, and that impairs the gate control mechanism, and you have to reset that, and these neuromodulators can help with that. There are things that can be done psychosocially with CBT. What you're seeing here are the factors that can modify pain, reducing anxiety, increasing reframing of information. The other thing is, as pain becomes more chronic, as shown on the right, you can get neurodegeneration, neuroplasticity, and this can lead to worsening or even chronicity of the pain. So you all know the monoamine hypothesis. You get reuptake at the presynaptic cleft with depression or with chronic pain. You can use antidepressants to prevent the reuptake, flood the synaptic cleft, desensitize it, and that may lead to reduction in pain. But the other component to that is the neurons that can become neuroplastic. And this is, if you look at the slide on the bottom, your basal neurogenesis with stress or chronic pain or illness can lead to suppression of neurogenesis, but proper treatment with the neuromodulators or psychological treatment can lead to restored neurogenesis. And this plays an important role on getting these, I'll give you an example. Here's a study where they looked at brain damage in mice. The yellow and the blue are the sham. The orange is the brain damage one trying to perform a cognitive task over time. And you can see the ability to do it is much less than the sham group. But if you give them imipramine, which is a tricyclic, you can see in the green that in 2 weeks they were able to improve their cognitive function and even exceed the performance at 4 weeks. And when you sacrifice these rats and you look at Ki-67, which is an RI precursor of brain cell growth, if you look on the right, there's much greater staining in that brain damage treated with imipramine compared to the one which is not treated with the antidepressant. Okay, so let's get down to the classes of the agents. You're all familiar with the tricyclics, the D classification, which is the noradrenergic specific serotonergic group, which is mirtazapine. These are both dirty drugs. They act as serotonergic alpha, adrenergic, muscarinic effects for the tricyclics. That's important because it may be helpful for the pain, but it also can produce side effects. The SSRIs just have serotonergic activation, whereas the SNRIs have noradrenergic and serotonergic, which is helpful for the pain with fewer side effects. So that's shown here. If you look at the top, the tricyclics have noradrenergic and serotonergic, but it also has antihistamine and acetylcholine antimuscarinic effects, which produce these side effects, whereas the SSRIs don't have noradrenergic effect, and it doesn't help for pain. The SNRIs are kind of a hybrid. It has noradrenergic and serotonergic effect, but it doesn't have the side effects of the tricyclics. So here you can see that for the tricyclics, with your histamine effect, you get sedation, you can get weight gain, constipation with the muscarinic effects. SSRIs are more anxiety and agitation. SNRIs are primarily nausea. Most of the other side effects can occur, but in lower percentages. Okay, so what do you want to use? Everybody talks about the tricyclics. I don't use it as much because I think there's a larger repertoire. And I think as you get more familiar with these agents, you can now, what do you do when the medicine doesn't work? Well, you can look at other options. But the dosing is 25 to 100. I recommend Alex Ford and his group came out with a recent paper showing that low-dose amitriptyline in the primary care setting using 10 to 30 milligrams was associated with improvement in subjective global assessment at 6 months. It also was associated with a reduction in the IBS-SSS severity score significantly. I think you could start with 25. If you want to start with 10, that's okay, but it may not be enough. You have to be able to increase the dosing. We've done up to 150, but I think 100 is a reasonable top range. The SNRIs are cleaner. They are not as well studied for IBS or GI pain, but there's a wealth of literature in chronic pain syndromes in other areas, fibromyalgia, peripheral neuropathy, cancer pain, and the like. Usually I go with 30 to 90 milligrams with duloxetine, which is Cymbalta. Another agent, which is another SNRI, is milnacipran or Savella, which has more neuroadrenergic effect. And it's used for fibromyalgia and diabetic neuropathy. It's not marketed in the U.S. as an antidepressant. You can tell your patient it's not used in the U.S. as an antidepressant if you want to convince them to use it for the pain. The SSRIs, as I mentioned, we can use it as a co-treatment when there's a high level of anxiety, but not primarily for pain. There are some studies to suggest that in esophageal pain, there might be some benefit. Mirtazapine is that other agent that has multiple receptor effects, so it has multiple side effects. Some of that can be used to your advantage, in particular sleep and weight gain for patients who are orthorexic or have lost a great deal of weight. It can be used in psychiatry for major depression like all the others. Buspirone is a azaparone. It's an anti-anxiety agent. It doesn't act on the benzo, but on the GABA receptor. And it has to be treated, you have to treat up over several weeks. It's used in GI based on Jan Tak's work for postprandial distress syndrome. It reduces early satiety and fullness that occurs. The antipsychotics, I wish they weren't called that, but I call them atypicals, have multiple effects, primarily antidopaminergic, but it also has serotonergic, muscarinic, histaminic effects as well. I'm going to focus on olanzapine and quetiapine because those are the ones that have been most studied in GI for pain, some of that from our group. The FDA has approved it for schizophrenia and bipolar in 10 times greater doses than what we're talking about, up to 800 milligrams a day. We're talking about 25, 50, maybe 100 milligrams. It can augment antidepressant treatment. You can add it as a secondary agent with chronic abdominal pain. There is some evidence to show that it can help as monotherapy, though I wouldn't recommend it. I think you're more comfortable with the antidepressant first. I would use this as an add-on. There are benefits in terms of sedation and anxiety reduction and sleep. It can help patients in terms of, in fact, in primary care, lots of doctors use it to help patients sleep along with doxepin. Olanzapine seems to have a lot of benefit in terms of reducing nausea and vomiting. There's been studies to show in cancer chemotherapy to cisplatin, you get reduction in nausea and vomiting. The side effects are shown here. You do need to watch for weight gain, particularly if you're combining it with an antidepressant. This kind of summarizes the targets. If you start with the abdominal pain, the tricyclics and the SNRIs are the ones that you would use most, not the SSRIs. The tetracyclines have some value, and the atypical for augmentation. If you want to increase transit rate, treat constipation, your SSRIs would do that. If you want to decrease transit rate, people with IBS-D, you can use tricyclics or SNRIs or tetracyclics. And then if you have anxiety reduction will occur. Not very much with the doses you're using with tricyclics unless you get up to about 75 or 100 milligrams. But the SNRIs and SSRIs, even in low doses, are helpful for anxiety. For nausea, The mirtazapine is the agent that you can use to increase weight, increase appetite, and the atypical olanzapine I've mentioned before. And of course, they all can be used for depression. Alpha-2 ligands, that's a peripheral neuromodulator. It has some central effect, and we use it often for treating pain, mostly neuropathic pain. There's at least one study that showed it could help for central pain. And that can be also added to a TCA or SNRI to augment. The side effects are shown at the bottom. Keep in mind that there's a effect on the first few days, first week or so, that what you're watching for is side effects and trying to mitigate that. Have the patient stay on it or reduce the dose, but don't get them off it. Don't switch from one drug to the other. It's not helpful, because if you keep them on it long enough, for a week or two, the side effects diminish and you start to get benefit, but you don't get benefit from the neuromodulators in the first few days. There is some evidence that you don't have to wait 4 to 6 weeks like we tell everybody. There's some evidence that if you get a response in 2 weeks, that gives you a 60% chance or prediction that they'll benefit long term. All right, let's talk about side effects. This is too busy, so I'm going to try to summarize the side effects. Central neuromodulators cause weight gain, and it tends to be dose-related because of their histaminic and primarily dopaminergic, serotonergic effects. Well, the atypicals give the most, especially if you combine with an antidepressant. The antidepressants can cause weight gain, not as much as the atypicals, where I said greater than 50% will gain 5 to 10 pounds. With the antidepressants, about 25% will gain 5 to 10 pounds. The tricyclics are the one most likely to cause weight gain, as well as mirtazapine, the SSRIs and the SNRIs less. Wellbutrin actually can cause weight loss, but it's not usually targeted for treating chronic pain, mostly for co-treating depression. But you can keep them on, you can reduce the dose, make dietary changes, and of course there's always Ozempic. It's not that I'm advertising it. Pregnancy. About 5% of women are, by the time of birth, on an antidepressant, usually SSRIs. The TCAs, SSRIs, and SNRIs are generally considered safe with some small exceptions. SSRIs are more likely to be associated with preterm birth, miscarriage, low birth weight, and you can see the odds ratios. They're small, but they're significant. But we're talking about 12.6% versus 11.1%, significant in studies of 3,000 people. But the large database analyses that have been done, everybody worries about malformation, stillbirth. It shows that it is not significant in these large databases, even though that's always a concern. Mood stabilizers may affect postnatal development, but the consensus is that the risk of untreated depression outweighs the risk to the fetus. These studies were on depression. You can make a judgment in whether you want to make that for us. For our patients, we do tend to keep our patients on these medications if we're treating them for significant GI problems. Serotonin syndrome, not all that common, but we get scared when you get the severe cases. It leads to autonomic instability and neuromuscular hyperactivity. It's due to excess serotonin. Not so much with single drug treatment, except for SSRIs when you get up to 60 or 80 milligrams, but when they're in combination. It says that 1 to 2 over 1,000 exposed will get it. Watch out for hyperthermia. This is a more severe case. But most cases are the patient is agitated, has a rapid pulse, and sweats. And that's where you have to cut back and watch. It doesn't mean you have to switch or stop. There are criteria which I won't go into for the sake of time. There are other neuromodulators can be associated with other types of agents. The triptans, for example, anticonvulsants, they can enhance. So look at your combination treatments when you're putting them on a neuromodulator. Are they on a triptan or things like that? The treatment is to stop it, hydrate, and then we can go back in lower doses. All right, QT prolongation, we worry about that. You can even get torsade de pointe, and rare cases, sudden death. The tricyclics, again, are the ones more likely to do it. When I'm mentioning this, I want to mention to you that those studies were in psychiatry, and we're talking about 100 milligram, 150, 200 milligram. So if you're using a 25 milligram, you're in pretty good state at that point. But I just have to mention it in terms of the data. It can be associated with QT prolongation. So consider, when combined with other medications, again, certain antibiotics as shown here, antihistamines, antiemetics, and the triptans. When do you do an EKG? I generally don't do an EKG because the risk is so low unless the patient is older, has a cardiac history, or there's evidence of QT prolongation. I think it's not cost effective to do an EKG every time you're going to put someone on 50 milligrams of amitriptyline. If it occurs, you stop the medication, consider a cardiac consult, restart in lower dose. Okay, so when do you use them? This is a slide we've used to show how you build up, you ramp up based on severity. I think that for the neuromodulators, it's starting to shift to the left from more mild to moderate because it does have independent effect on treating IBS and other conditions. Mentioned about augmentation treatment. When it doesn't work, when you don't have an adequate response, you can increase the dose, but then you can add a second agent. It minimizes side effects because if you're at a dose of, say, 50 or 75 of a tricyclic and you want to add an atypical or gabapentin, you drop the dose down about 30 or 40%. This is to show that, of course, the patient-physician relationship, if Lynn's not going to mention it, please come to our workshop on communication skills this afternoon. The peripheral GI treatments, then you go to the neuromodulators or brain-gut therapy. You can increase the dose when you want to do augmentation, maybe get a psychiatric consult or read the papers. This is one of the models. You should have out there a card where you can look at this. On the backside are the doses of these medications. So I won't go through that for the sake of time, except to say that the top is showing you monotherapy, insufficient effect, restricted problems with side effects. Then you do augmentation, atypical antipsychotic, possibly an azaperone, delta ligand, or psychologic treatment. So when I tell a patient they're going on a neuromodulator, I tell them you may see benefit in 2 to 4, maybe 6 to 8 weeks. But if you're better, we want to keep you on it for 6 months to a year. Why? Because we now have some evidence that with neurogenesis, you may get to a state where they could get regrowth of those neurons, recircuitry of the wiring, which is something that other medications don't do, and then you can taper them off. So it allows them to stay with it. And if they are benefiting, they usually stay with it. There's a study that shows the improvement with continued treatment. Last two slides. I'm going to make it. Pharmacogenomic testing, I use it in about 20 to 30% of my patients who are often very complex. I like to use it when a patient comes to me and says, every medication I take, I get a side effect. I take one dose and I nearly died. And I'm beginning to say, maybe this is more nocebo. This is not necessarily a pharmacologic effect. Let's do pharmacogenomic testing and see how your body's handling it. Or if I have a patient that's not responding to any type of medication 2 or 3 times, then I'll do that to try to help select. Because what the pharmacogenomic testing is doing is telling you if the patient has interaction effects, if it's a rapid metabolizer or a slow metabolizer. If it's a rapid metabolizer, I could push the dose or switch. If it's a slow metabolizer, I could use lower doses or switch. So in summary, Low to modest doses of tricyclics provide the most convincing evidence of benefit for treating chronic GI pain and painful DGBI. Serotonin norepinephrine uptake inhibitors, or SNRIs, are also recommended, but due to limited data, additional studies are needed. I think the data are there, it's just not been in GI as much. Augmentation, that is adding an agent like an atypical antipsychotic or a delta ligand or an azaperone or brain-gut behavioral therapy is recommended when monotherapy is unsuccessful or produces side effects at higher doses. Remember, you can drop the dose when you augment. Treatment should be continued for 6 to 12 months to potentially prevent relapse, presumably due to neurogenetic effects. And implementation of successful treatment requires effective communication skills to improve patient acceptance and adherence and to optimize the patient-provider relationship. Thank you.
Thank you, Doug. I think it could be a lot of good questions and discussion on the panel because there's a lot of good information, but we can talk about it more. I just want to, as I mentioned this morning, Dr. Oster woke up this morning, wasn't feeling well, but I just wanted to just briefly go through some of her slides because you'll have access to slides, but I just want you to know the content that is in here. And what she really was going to talk about is more practically how you would screen these patients who would benefit from brain-gut behavior therapy, which is the term we're using now rather than psychotherapy or behavioral therapy. It's brain-gut behavior therapy because it's working along the brain-gut axis. So it was really about she wanted to first just talk about the evidence. And there is really growing evidence that these brain-gut behavior therapies like cognitive behavioral therapy, gut-directed hypnotherapy, mindfulness-based stress reduction are efficacious for these patients with disorders of gut-brain interaction. And Andrea went over that as well as in the systematic review or the network meta-analysis, actually. So there's definitely ways that we can target stress sensitivity, stress responsiveness, catastrophizing behaviors, thoughts, and also avoidance behaviors with these brain-gut behavior therapies. I thought what was nice on this slide that she made was who are the good candidates for these therapies. And what she mentioned here is patients who have anxiety related to their GI symptoms, this GI symptom-related anxiety, patients who are avoiding GI procedures, imaging, tests, patients who worry, they have anxiety about food, diet, the impact on their GI symptoms, avoidance behaviors. And actually, Tony and I saw a patient with pretty extreme avoidance behaviors. I mean, more than I think I've seen a lot in my clinic. And this is a tertiary care referral population that I see. Patients who have difficulty managing their GI pain, stress, particularly the uncontrollable stressors, that's really impactful on mental and physical health. And patients who have emotional difficulties adjusting to their new diagnosis or just having a chronic illness. So I thought this was a very nice table that you can refer to on the left. Who are those appropriate candidates? And these are really patients that are interested, they're motivated, they understand that having brain-gut behavioral therapy would be an important component in them managing their symptoms. Again, people with stress-sensitive symptoms, more emotional factors, and maladaptive coping behaviors. Patients who really have a quality of life impact, and you're really just trying to help them manage their symptoms so they can have better daily functioning. And those who have moderate severe symptoms that are refractory to our initial treatments. But the inappropriate candidates, which I think a lot of GI health psychologists really want to hit home to referring healthcare providers, are those patients who really have unstable medical condition that really needs their attention first. And then a lot of these patients could have more of this disabling, very prominent anxiety, obsessive compulsive behavior, PTSD, which we see a lot in our clinics, eating behaviors. So it makes it more challenging for them to really focus on their GI symptoms and start implementing these brain-gut behavior therapies. So often having that managed first, or even co-managing it with a psychiatrist or a general psychologist who can help with those symptoms, because really the GI health psychology is really meant to focus on the management of the GI symptoms. And then she also will include, and you can look in this as what should I ask my patients? And it depends on what you're looking for. So you can really look, I have trouble seeing the screen, but you can look in here just for example, like GI symptom related anxiety is, what worries you the most about your GI symptoms. But I would say that you could take a look at this if you're trying to assess these different aspects of their clinical presentation and what they're experiencing. I also thought this was really helpful on the screening questions, and it used this acronym ACT UP. So A, activities. How are your GI symptoms affecting your life? C, coping. How do you cope with this GI condition? I do remember the IFFGD did say many years ago that patients get a little sensitive using the word coping. So I tend to say, how are you managing your symptoms? And T is think. Do you think your GI condition will ever get better? U is upset. How have you been feeling worried or down? What has been going well recently despite your GI symptoms? And P is people is really about support. What support are you having? And how are people reacting to when you have these symptoms? Because that's a lot of what they're experiencing that we don't see in clinic. And it's really important to get a good perspective of what is happening to them 24/7, that we're only seeing them for 15 minutes, 30 minutes or an hour. So what Megan had mentioned is about this 5 steps of referring your patients, discussing brain-gut interaction, introducing these behavioral therapies, explaining the scientific rationale and the data to support that they can be efficacious, and how brain-gut behavior therapy, as I just mentioned, is different than general psychotherapy. It's not really like talking about your mother, so hopefully my children won't be talking about me when they go to therapy one day. And then also to express commitment to stay engaged in your care, because these take a while. And they've shown studies that even though you give them a short course, 10 weeks, 12 weeks, or a certain number of sessions, that the benefit of behavioral therapy can be many months later. They even see a augmented benefit a year later. And so that patients really want to stay engaged with these treatments, and when that treatment course is done, to still be practicing what they learned. This is also for your benefit is external referral resources for brain-gut behavior therapies. The first one is gipsychology.com. This is a group of GI psychologists that give virtual care, and they are, I believe, licensed in each state in the United States, and you can just go on the website and the patient can actually sign up for them, or as a physician or healthcare provider, you can also refer them. Rome Foundation has a gastropsych website, so if you go on that website, you will see a GI registry of GI psychologists who have been vetted by experienced GI psychologists for DGBIs, and you could look up each state and it'll give you a list and context for these different psychologists. And also these other referrals to these other healthcare providers. But again, you have access to those resources on the slides. Okay, I want to start with the patient. We have a lot of these. Okay, questions. And I came up with some, but we do have some questions in the audience. So this is for Dr. Drossman. When combining tricyclics and SSRIs, what doses are you comfortable with, particularly since you brought up the serotonin syndrome? And if you can answer the second question, because this does come up, do you ever combine SNRI with the SSRI?
Either a tricyclic or an SNRI can be combined with an SSRI if there's a large dominant anxiety component, although SNRIs can be helpful for anxiety as monotherapy, so I'd go with that first. If it's insufficient with a tricyclic, I certainly would combine it. The tricyclics you're going to be typically using are not high enough because of side effects. So if you're using 25 or 50 milligrams, it's perfectly fine to add 10 milligrams of an SSRI or even 20. When you take an SSRI and you go from 20 to 40, you're giving much more serotonergic effect than going with 20 of an SSRI and 50 of a tricyclic, because there's very little serotonergic effect in comparison. Does that answer your question?
Yeah, did you do this SNRI and SSRI?
I said I do at times use an SNRI and an SSRI, not as frequently, because usually if I go to a higher dose, I do get an anti-anxiety effect. I don't use it to help enhance the pain benefit. The SSRIs won't help with that.
Okay, so, SNRIs like duloxetine are FDA approved for anxiety, depression, neuropathic pain, fibromyalgia. But what is your sense of how you would compare in someone who has more of these anxiety types of behaviors? Do you think that SSRI works better than SNRI in that situation? Or do you think they're pretty comparable?
Yeah, I think if it's a dominant anxiety, I would go with an SSRI. And then if there's a lot of pain, I would then add either the tricyclic or the SNRI.
Yeah. Okay, so you talked a lot about how many of these antipsychotics increase weight, which is an issue. Even in people that have lost weight, it's an issue. I think one of the questions was, are there any antidepressants, antipsychotics that do not cause a weight gain or lethargy? Now, you did mention Topamax and Wellbutrin. People can lose weight on that. But when do you use those two as augmenting agents?
Generally, I don't use Topamax as I use that for cyclic vomiting or abdominal migraine. I don't usually use it for chronic pain. I just put it in the slide. But SSRIs do not necessarily cause weight gain. They can cause weight loss, at least in the beginning. As patients get better, they might start to gain weight.
Right. Okay. So today we talked about a case, and Rachel, you presented a case on epigastric pain syndrome, which is somewhat different than the postprandial distress syndrome of functional dyspepsia, which is much more it's most postprandial non-pain symptoms. There's IBS and there's centrally mediated abdominal pain syndrome. So I just want to I want to know from the panel, how would you treat those differently? If someone had epigastric pain and somebody had more central CAPS, the centrally mediated abdominal pain, or they had IBS, what does the panel use? And maybe we can go down, I don't know, not so much for dietary treatment, but what would you guys use? And how do you differentiate the two? And would you use different agents for these different pain predominant DGBIs? Yeah, why don't you start?
Well, if it's IBS, then I'd be tagging it to something that has effect on bowel function. If it's IBS-C and you use linaclotide because of the cyclic effect in the enteric nervous system, you could get pain benefit after a month or two. If it's CAPS, I'm using purely central neuromodulators and augmenting it. If it's EPS, if there's a PDS component, I might use mirtazapine or buspirone. But in general, I would probably go the same route of the tricyclic type of agent for the pain dominance.
Yeah, because
I would also use a H2 blocker or a PPI first.
Okay, because really buspirone and mirtazapine was studied in postprandial distress syndrome, not so much epigastric pain syndrome. However, I think mirtazapine can help with more of the pain, but not so much buspirone.
Well, his study he called it functional dyspepsia, and that was a combination of patients. So he didn't parse that out, but we presume it's due to the PDS. Right?
But do you really think buspirone helps pain?
Buspirone is used as an augmenting agent, not as a primary agent.
Yeah.
Just like in psychiatry, you can use buspirone as an augmenting agent.
Yeah. So, Andrea, how do you approach abdominal pain, and how do you decide which neuromodulator to use or what type of treatment you would use?
I think I use a very similar approach. I mean, with IBS, we're fortunate with all the recent clinical trial data that we have IBS-specific agents that can treat both bowel dysfunction and, also pain. So I'll usually start with that specifically, and then reach for neuromodulating agents earlier in CAPS or EPS. I do use TCAs in EPS sometimes because I do think they have a beneficial effect for pain, but obviously I have to understand what their baseline bowel function is like as well to try to avoid any side effects.
What about you, Rachel?
Yeah, I mean, I haven't seen that many patients with CAPS yet, but the way that I think about it is maybe more of a diffuse or constant abdominal pain than an EPS, where in the case of our patient, he really had the progressively worsening pain between meals. And so I really like to individualize it to the patient and kind of use the side effects of neuromodulators if we're using them to the benefit of their particular bowel habit or situation. So if the patient has IBS with diarrhea, if I'm using a neuromodulator, I might use a neuromodulator that has more of a constipating side effect than a patient with IBS with constipation, where I might tend towards an SNRI like duloxetine that is not as constipating. But in general, I also like to think about like not just neuromodulators, but are there other lifestyle, including diet and brain gut behavior therapy, but also eating more frequent meals, like, logical next steps for someone who has progressively worsening pain, waiting between meals. So just trying to think globally about this specific patient.
Yeah, and before Tony can answer, I think it's really important to differentiate the CAPS, which is continuous abdominal pain, doesn't stop. The EPS, IBS are more intermittent. So you could introduce some peripheral therapies, but really for CAPS, you have to think about a central neuromodulator and brain gut behavior therapy, or addressing just general psychotherapy if you had these coexistent conditions like I mentioned. So Tony, how would you approach it differently if it's EPS, IBS, CAPS for your treatment?
Pretty much similar to what Dr. Drossman, Dr. Shin, and Dr. Sarnoff have all said at this point. And it just depends. So like physiologically with CAPS, usually it's not related to any physiologic events like eating or bowel movements, which distinguishes it from EPS and IBS. I know EPS, the sort of postprandial nature is a suggestive feature, but it's not always diagnostic. It's helpful. The one thing I would say is with EPS, this is like a low-hanging fruit that we often try as a PPI, very, very low rate of response, but just something that we often do in general GI. Sometimes encapsulated peppermint with caraway oil is helpful as a trial, like FD Guard. Oh, I'm not supposed to use trade names, sorry.
Well, you can say verbally, but yeah, not in slides. Yeah.
Okay, encapsulated peppermint with caraway. So that is sometimes a helpful trial. And some people note that it takes the edge off the pain, which is helpful. But I think like everyone was saying, with IBS, you have a lot more treatment options. And then there's always the central treatments and then the peripheral treatments based on the subtype of IBS that you're dealing with. You have a lot of options for pain and bowel habits. And then for CAPS, I agree. I think oftentimes we reach very quickly for the neuromodulators because there's not a lot of other treatment options. But actually in some of the patients that we've seen in clinic, I think the biopsychosocial part of it predominates. Oftentimes the pain that they're describing is actually really not that bad, but there's a lot of fear and avoidant behavior around the symptoms and aggravating them. So they get scared that there's they come up with associations, sort of understandably trying to seek a relationship between, behaviors within their control and the symptoms, and maybe coming up with some misconceptions about what those associations would be, and coming up with essentially maladaptive coping behavior. So a lot of the treatment ends up being directed towards helping them with psychoeducation, helping them understand the physiology of CAPS, that maybe some of these associations they've made are not necessarily physiologically based, and that we have to sort of promote them to kind of break out of this, I think, fear response to try and get them to expand their sort of lifestyle and get back to a place of normalcy, because usually there's a pretty significant impairment in quality.
Yeah, I think you're bringing up a really good point, which takes time, but it's not just determining what's the best neuromodulator or even explaining why a neuromodulator works, but putting in the context of their experience and other aspects, like you mentioned, the biopsychosocial features, and Doug really used that term, implied it for DGBIs, are so important to address too. So you're using it, really integrating that approach. Kate, are there any diet therapies that you feel are really beneficial to target abdominal pain per se? Not so much diarrhea or constipation, but abdominal pain.
Yeah, so with EPS, it's a bit of a different set of considerations on the dietary side. As Rachel mentioned, the smaller, more frequent meal pattern can be very beneficial. And, sometimes that's something, it feels basic, but a lot of patients aren't necessarily following that type of pattern. One kind of added benefit with that is that if there are dietary triggers, it naturally spaces them out more across the day. And oftentimes dietary triggers are dose dependent. So having those more spaced out across the day can reduce the likelihood of symptoms with meals. There's also specific dietary triggers that might be more likely with upper abdominal pain, including things like spicy food, which came up in the case study. More acidic foods can be more of a trigger for the upper abdominal pain. And then certain beverages like alcohol, carbonated beverages, coffee can commonly play a role. So with EPS, I'm more commonly starting with some of these known upper GI irritants and triggers. There is evidence for low FODMAP diet for abdominal pain in general, but less likely to be a first-line intervention for someone who's having more upper and postprandial distress.
Okay. So we're going to have to wrap up soon, but I wanted to ask the last question because we don't all have access to brain gut behavioral therapists. So we have these digital apps now, like Nerva, MetaMe, or Regular, I should say, Zemity, Mahana. So when do you guys think that we should refer a patient to a digital behavioral app? You don't do that because you're not looking. You're not answering.
I do. It's complicated because it's just the nature of my practice. They usually have so much other comorbidities that they're not going to be as beneficial as the more, I think mild to moderate is a good way to look at it.
Yeah.
Not a lot of significant comorbidities and not competing with a brain gut behavioral therapist. That's what I would recommend.
What do you think, Andrea, about supplementing, maybe waiting while you're waiting for an appointment? Maybe the course is ending. What do you think? How would you bring that in?
I've had a handful of patients who've done this, and I think it's most useful for people who are really proactive about their health and actually have expressed that they really do buy into the model, the biopsychosocial model of DGBIs. And so these are people who will probably be more motivated to, give these digital apps like a valid attempt and stick with it because it will take time.
Does anyone else want to add anything before we end about that or anything?
I would just add that I think also in the digital age and with maybe Gen Z and millennial patients, there might be actually more comfort with interfacing with an app rather than with an actual human. That is something that I feel like I'm seeing more and more. And so that might be sort of a gateway that we could take advantage of.
Yeah, the one benefit with a human is that they could have nuances and personalize it to the individuals, and some people just have preferences.